Hello and welcome to the Medicine Matters Diabetes podcast. I'm Eleanor McDermott. We're marking the 25th anniversary of the EASD's Psychosocial Aspects of Diabetes study group by talking to experts in the field about some of the key issues in psychosocial research and care. For this edition, I'm talking to Professor Bill Polonsky from the University of California at San Diego about diabetes distress. Well, can you start off by defining it, please?
Well, I should be able to do that. So we've been studying what we call diabetes distress or diabetes-related emotional distress since the early 90s. And it was a way of trying to appreciate and understand that so many of our patients weren't just in denial of their diabetes or weren't just quote unquote being non-compliant, but they actually had important thoughts and feelings and attitudes about this disease that had not been looked at before. And this broad category we refer to as diabetes distress. And really what we're looking at is the degree to which they report different ways in which living every day with diabetes has become or remains a problem for them. A problem for them in terms of very, very specifically the emotional elements like feeling powerless and out of control, or the degree to which the stuff they have to do, the regimen is driving them nuts, interpersonal elements that they perceive as being problematic, etc. So it's really, at least in terms of the ways which we have developed assessment approaches, it's how is diabetes problematic for you, and how can we understand that better and think about how to address that?
How common is it?
Well, that's a very good question. In the studies that we have done, which have mostly been clinic-based or in our own large surveys, we've seen it be as high as 30% or higher. And that's based on the cutoff scores that we've developed in our own instruments. However, we have seen data from other countries that have looked at not just clinic populations, but have looked at broader populations where the percentages are much lower, as low as maybe 10, 12%, and possibly, again, even lower. So I've been impressed by those studies. So I guess I can't really tell you, but I'd certainly say I'm comfortable saying it's at least 10, maybe 15%, and in our populations, a lot higher than that.
And are we talking type 1 or type 2 here?
Again, I'm going to rely on the studies we've done. We've seen similar percentages. So again, in our studies where we see in clinic populations at least 30% or higher, it's pretty much the same in type 1 and in type 2s.
How does it interact with anxiety, depression, and disease burden?
Well, there's an overlap with depression. If I remember correctly from the most recent studies, we see a correlation of about 0.3, and it can be even higher. We understand why, that what diabetes distress and depression have in common is a sense of feeling out of control or powerlessness, probably the core cognitive feature of depression. And we know it's not just cognitive, but cognitive feature of depression is feeling powerless. Bad things are happening to me, and it feels like there's nothing I can do about it. And quite similarly, when we think about diabetes distress, it feels like diabetes is feeling out of control, and it often feels like I'm struggling. I don't know quite how to address it. There's nothing I can do about it. So we believe that's what that overlap is about. That overlap can be stronger, and that's important because what we've also seen is in studies where we have looked at people who score high on depression questionnaires, those people actually don't meet criteria once you interview them for a depressive disorder, even though they score high on depression questionnaires. And what those high depression scores mean is often indicative of diabetes distress, not profound or pervasive depression per se. It's just people being fed up, overwhelmed, beaten down by their diabetes.
What makes people more or less susceptible to developing diabetes distress?
With my research hat on, I'd say I'm not quite sure, but I can put on my clinician hat and see if I can muse about that in terms of that from all the many thousands of patients we've seen. Diabetes distress certainly seems more common in, let me think about that. Well, I guess I want to back up for a moment here. Part of the reason and part of the point we make to all of our groups that we meet with and all of our patients is that because we see relatively, in our own studies, relatively high levels of diabetes distress, and I want to be clear, we have these markers with our scales. So when I say high levels, I'm talking about people who meet criteria for what we call moderate diabetes distress. That's when we see levels of 30% or higher. So they could be moderate or even severe. And the point we're always making to folks is that if you have gone through times or going through times now where you're feeling fed up, overwhelmed, distressed about your diabetes, it may mean you're just normal. That we know, again, that that's very common. In terms of why is it that some people score relatively low versus those who score high, again, a lot of it just has to do with what they've experienced with their diabetes, how they cope with this disease, what kind of support they're receiving. I've certainly been impressed that in other countries that have better healthcare systems than we have in the US, oftentimes we see lower levels of diabetes distress. And again, I think it's because these people are not so abandoned with this disease. They have some degree of perceiving that they've got a team that's working with them. They've been given messages of hope that with good care and effort, they can do well with this disease. So I guess one important element that I've been thinking about a lot is this degree to which there is a rational and well-functioning healthcare system that supports people with this illness.
How regularly should we be screening people for diabetes distress?
We tend to recommend this is something that should happen probably at least once a year. Again, we've done, I'm very proud of my colleagues that we've developed such nice, simple measures for measuring distress. It's very easy to do. We even have websites where people can go check it out and evaluate themselves. But at least once a year in a clinic setting, just like we would say with lipid levels, to check in with someone and say, how are you doing with your diabetes? And even though we have very simple questionnaires for people to use, oftentimes when healthcare providers ask me about which questionnaire they should use, I say even a simpler thing to do is, rather than using a questionnaire, to take 2 or 3 minutes with the individual, again, at least once a year, to simply ask them, Mr. Smith, it's nice to see you. Can you tell me one thing about diabetes that's driving you crazy? To make room for that as being an issue. We normalize the possibility of it being an issue by asking a question in that way. But that's just being respectful of folks, and it opens the door to talk about these things. I should mention the reason it is of value for healthcare providers to talk about, not just because it's a nice thing to do for one's patients, but because it's meaningful in terms of what we've learned about how elevated levels of diabetes distress are associated with problematic cardiometabolic control. People tend to have higher A1Cs, for example. It's important to note that we don't see that with depression. Depression scores are typically across studies not associated with elevated A1C, but elevated diabetes distress is. So if we want to make a difference in helping our patients get to a safer place, cardiometabolically speaking, it's of value, of enormous value, to help people deal with how overwhelmed, how beaten down, how freaked out they are about their diabetes.
Does diabetes distress affect people's relationships with their healthcare providers?
I will say, clinically speaking, we know that one of the reasons why people will express high levels of emotional distress is, again, feeling isolated, alone, abandoned with their diabetes, or blamed and shamed by their healthcare providers. So We know that the healthcare setting and the relation with healthcare professionals can make a big difference. It's one of the reasons why issues of healthcare provider relationships are all of our questionnaires that assess diabetes distress. However, I would also add that in all the studies that we've done, as we look at the different elements that contribute to diabetes distress, relationships with healthcare providers actually is one of the lower scoring series of items. It's one of the seems to be less impactful than others. I'm not even sure I should say less impactful, less contributing to diabetes distress than others. So the larger issues have to do with, again, feeling powerless and out of control, feeling frustrated with the regimen, feeling aggravated with family and friends, things like that really seem to be much more central for folks than the issue of their health provider. That probably makes sense simply because people don't eat or think about their healthcare providers as often as they're having to think about their diabetes and their loved one every single day.
In addition to simply asking people if their diabetes is a bother to them, what else can we do to help people who have diabetes distress?
Again, another really good question. And the reason I always start by saying, you at least ask, is the most important way in which we begin to address diabetes distress is to normalize it for folks. So by caring enough or being respectful enough to even bring up the subject, we're already doing an important intervention. And by then acknowledging when someone tells us the elements of which they're fed up or overwhelmed with their diabetes, letting them know that that's common, that that's normal, and by giving that a label, calling that diabetes distress, we've already made a powerful intervention. In terms of what we've learned about what really makes a difference for folks, we know that the isolation of diabetes is very important. So by helping to connect people with others, it's one of the reasons why we've seen so much efficacy in many of our group interventions. We know that addressing the powerlessness issue is very critical. So we spend a fair amount of time as we've developed interventions focusing on the element of hopelessness and how much effort we've put into helping people understand and change their beliefs and attitudes about diabetes and helping them to know that with good effort and good care, odds are good you can do well and live a long and healthy life with this disease. That element of hopelessness is key. Getting into the weeds with folks about the stuff they have to do every day and realizing they don't do everything, but helping them identify the actions that they can take that can really make a big difference and how they can manage diabetes without having to feel overwhelmed by the tasks that have been recommended, and to put aside the sense of blame, shame, and resulting feeling of failure that develop with folks. So having regimens that people can do so that they can feel a sense of success are really critical. So those are sort of, and again, I know we're being limited here in terms of time, but those are some of the ways in which we know we can make an enormous difference. In fact, if there's one thing that we have learned over the course of years, is not only what a large issue diabetes stress is and how important it is, but that in fact we can address it and we can help people to feel well and do well.
Do you think there are any big gaps remaining in our knowledge about diabetes distress?
No, I think we've got it all. Thanks. No, just kidding. Oh gosh, I guess I'm so stunned by your question because there's so many gaps. I'm not even sure
where to start.
Yeah, it's a brain freeze for me when you ask me that question. Yeah, I mean, when I think about gaps in distress, I've been talking with you very blithely about what we understand and what we do. I don't really think we've gone as far as we need to. I think most importantly, we have, in terms of published data, in terms of ongoing studies, actually remarkably little to help us document what really works and what really makes a difference. To me, that's really the hope for the future, and that's where so much of our effort and research and early needs to go. Can we identify simple interventions that can really help people to recover from high levels of diabetes distress. That probably is the most critical gap in the area we're most concerned on, and where I know my colleagues and I and others around the world are starting to focus on more now.
Thank you to Bill. And thank you for listening to this podcast, produced by Midwire News for Medicine Matters Diabetes. Please subscribe for more, and don't forget to visit diabetes.medicinematters.com for news, expert opinion and practical advice about caring for people with diabetes.